Good day YouTube and good day world, welcome back to my channel. If you're new to the channel, my name is John and you're very much welcome. So last time we talked about sepsis, which is a life-threatening condition which results from the infection in the body. Also, we've touched the vulnerable population or the group of people who've got higher risk in developing the condition. Also, we discussed the pathophysiology as well as the symptomatology or the signs and symptoms of sepsis. So for today, we're going to tackle sepsis management. So we are going to focus on the treatment and we'll call them the Sepsis Six. Before I begin, I'd like to greet my family, my friends in TCG, Dikis and Kuligligs, and my colleagues. I hope you're doing well today. Also for Liba, Tanya, and Jency, I wish you all the best with your Roski. You can do it. Also, shout out to Ate Cecilia Cole and her husband Ashley and their business, which is The Fat Pig. So if you could visit thefatpig.co.uk, that would be highly appreciated. If you're looking for an event caterer for various occasions, including corporate events, weddings, birthdays, anniversaries, or graduations, then you may keep in touch with the business team. So just visit their website, that's thefatpig.co.uk. So going back to the topic. Sepsis 6 is the term given to a group of medical diagnostics and treatment aimed to reduce mortality or death of sepsis patients. These are 6 actions and they are grouped into diagnostic and therapeutic. Diagnostic meaning these actions working to detect and figure out the source of the infection in our sepsis, and then therapeutic aims to treat the cause of sepsis and the condition itself. And for our vlog today, we'll aim to remember Sepsis 6 with a mnemonic, and that is BOYA. BOYA. That spells as B-L-U-O-A-F. BOYA. So let's begin. The first among the Sepsis 6 is taking blood cultures. So the first one in our Sepsis 6 under the diagnostic subgroup is taking a blood culture. This enables us to find out the bug or the microorganism causing the infection and check which medications they are sensitive to. This also involves taking blood from a vessel to find out the source of sepsis, for instance, the bloodstream. Blood culture can be obtained initially from the periphery or the vein, or in some cases from an artery through an arterial line, or from a large vein such as the intrajugular, subclavian, or femoral vein through a central venous axis or a central line. Aside from blood cultures, we may consider other sources to find out our causative agent. This may include sputum to check for chest infection, urine to check for urinary tract infection, UTI or urosepsis, a wound swab to check for wound infections such as in surgical wounds and cellulitis, and then cerebrospinal fluid or CSF to rule out meningitis. Just gentle reminders about taking blood cultures. Number 1, we should ensure it's done aseptically. This is to prevent contamination of the specimen and having an inaccurate finding. For instance, wrong microbes may be detected from the sample, which leads to wrong treatment. So remember to do this aseptically. Also, it is best to take blood cultures prior to antibiotic administration. This is done for 2 reasons. Number 1, antibiotics could kill the potential causative agent, leading to inaccurate results. And then number 2, it is best to identify the causative agent first so we would know what antibiotic to give. On to the second one, we have to check the lactate levels. Lactate is one of the substances the cells produce during cellular metabolism or cellular respiration. That's when the body converts food into energy. According to some sources, in sepsis, the body is experiencing hypoxia or low oxygen levels. So, the body cells would switch from aerobic respiration, which requires higher oxygen levels, into anaerobic respiration, which needs less amount of oxygen. Also, the body naturally produces lactate to fuel the cells in times of stress. Increased lactate is usually linked to conditions such as severe inflammatory response syndrome or SIRS or SIRS and sepsis. Lactate can be checked through blood sampling, which is initially obtained through the periphery if the patient is on the emergency department or A&E. The sample can also be obtained from the artery via an arterial line or through a central line in settings such as the high dependency unit or intensive care unit. Increased lactate may indicate hypoxia and dehydration since the body is under stress. Not to mention the increased nitric oxide production, which leads to vasodilation, increased tissue permeability and capillary leak, as well as the coagulopathies and clot formation. Since increased lactate may imply dehydration, fluid resuscitation is usually done. As per the 2014 Adult Sepsis Management Algorithm from the National Clinical Guidelines number 6 of the National Clinical Effectiveness Community or NICE, lactate levels equal or more than to 2 millimoles per liter will need fluid resuscitation. If lactate levels remain greater than or equal to 4 millimoles per liter despite the second fluid administration, it would be documented as septic shock. Then, fluid resuscitation would be continued and the patient would be referred to critical care. For the third diagnostic in our Sepsis 6, we've got checking urine sample. We have to measure the urine output as part of the Sepsis 6, as acute kidney injury or AKI is one of the consequences of reduced blood and oxygen supply in the kidneys. Take note that oliguria or inadequate urine output of 0.5 ml per kilogram per hour presents as one of the early signs of AKI. According to Graham Nemo and Mervyn Singer's ABC of Intensive Care, oliguria leads to anuric renal failure and the need to renal replacement therapy or RRT in about 5 to 10% of severe sepsis cases. In addition to urine output measurement, we may consider urine sampling, which can be obtained through a midstream urine or a catheter. Since the patient is already poorly or sick, catheter sampling urine is better. In line with urine sampling and measurement, we have to observe a sepsis during the procedure. Also, it is best to commence a fluid balance chart to keep an eye on the fluid volume excess and deficit. So for our therapeutic action, we've got administration of oxygen. Tachypnea or fast breathing is an early indicator of severe sepsis. Thus, we administer oxygen as part of the Sepsis 6 to counter hypoxia related to the diminished blood supply, secondary to vasodilation, capillary leak, and clot formation. Keep in mind that the ideal oxygen saturation target is more than or equal to 94% for an average adult and 88 to 92% for those who are carbon dioxide retainers, such as those with chronic obstructive pulmonary disease or COPD. But why do we aim for 88 to 92% with carbon dioxide retainers? The reason is giving too much oxygen than how much they need would suppress their breathing drive, which may lead to breathing cessation or respiratory arrest. Things to remember in oxygen administration: we may use various oxygen delivery equipment depending on the patient's oxygen saturation levels. We may give 1 to 4 liters per minute of oxygen via nasal cannula or nasal prongs, 5 to 10 liters per minute via simple face mask, and 2 to 15 liters per minute via Venturi mask depending on the oxygen saturation, and 10 to 15 liters per minute via non-rebreathe mask. If the saturation does not get better, we may consider other means such as your continuous positive airway pressure or your CPAP, as well as your bi-level positive airway pressure or your BiPAP. Now we've boosted the oxygenation in the body, the next one would be the administration of empirical antibiotics. Empirical antibiotics are given in sepsis to defeat its potential microbial cause. Antibiotics may be given as combos, as NICE recommends initially giving empiric antimicrobial therapy of 1 or more antibiotics that antagonize all potential pathogens and effectively go into tissues in adequate concentrations. Things to remember: antibiotics should be started as early as possible. It was found that delay in antibiotic administration was associated with increased hospital mortality, while rapid administration was linked to lower in-hospital mortality. Also, we should consider medication allergies such as penicillin. Alternative antibiotics can be used to prevent anaphylactic reactions due to drug allergies. In addition, it is vital not to miss the dose as much as possible so as to prevent antibiotic resistance, which could pose a greater threat or challenge in sepsis treatment and management. The antibiotics should also be reviewed after a day or two with the patient's blood results to evaluate the effectiveness of the treatment. In some hospitals, they use 3 antibiotics. First one is metronidazole, the next one is gentamicin, and the third one is amoxicillin. In some cases in which the patient has got allergies to penicillin, then amoxicillin can be changed to vancomycin. And what do you think is missing in our Sepsis 6? Yes, you're right. We've got fluid administration. Fluid resuscitation helps manage hypovolemia or low fluid volume and hyperlactatemia or increased lactate levels in the blood through intravascular volume preservation, fluid loss replacement, and organ dysfunction support. As per the UK Sepsis Trust Sepsis Screening and Action Tool, 500 ml of stat isotonic crystalloids like your 0.9% sodium chloride or normal saline could be given if the patient is hypotensive or has a low blood pressure, or if the lactate level is more than 2 millimoles per liter. The 2014 NICE guidelines advise fluid resuscitation of 30 ml per kilogram in an hour. If hyperlactatemia still persists, it is now documented as septic shock. Then, fluid resuscitation is to continue and the patient is referred to critical care. In giving intravenous fluids, we should watch out for signs of fluid overload, which include reduced oxygen saturation, shortness of breath, crackles on auscultation, and jugular vein distension. If hypotension isn't resolved with intravenous fluids, we may then consider adding inotropes into the equation. Inotropes are medications that raise blood pressure. For instance, metaraminol can be given peripherally, while the more potent noradrenaline and vasopressin would require a central venous axis or a central line. Just a few reminders. If after delivering the Sepsis 6 and the patient is still tachypnic with a respiratory rate of more than 25 cycles per minute, hypotensive with a systolic blood pressure of less than 90 mm mercury, hyperlactatemic, has a reduced level of consciousness, or is obviously critically ill at any time, it is best to contact the critical care outreach ASAP or as soon as possible. Critical care outreach teams are equipped with intensive care skills to help patients with or at risk of critical illness receiving care in areas outside the ICU or the intensive care unit. And for our quote of the day, it's from no other than Florence Nightingale, or Mother Florence. She said that wise and humane management of the patient is the best safeguard against infection. In my view, this means we have to observe safe, evidence-based, and compassionate healthcare practice for the patient's best interest to prevent infection. Examples include assessing the lines for any signs of phlebitis, obtaining blood specimen and giving intravenous medications using the principles of asepsis, and remember, practicing hand hygiene as the universal measure to prevent or counter infection. With those in mind, we'll be able to promote our patients' health and get them better. There you go, guys. Now you've got the Sepsis 6. In summary, the Sepsis 6 is divided into the diagnostic and the therapeutic actions. So for the diagnostic ones, again, we've got taking blood cultures, checking lactate levels, and checking the urine output or measuring the urine output. Then, for the therapeutic actions, we've got oxygen administration, empirical antibiotic administration, and lastly, we've got fluid administration. So guys, this ends our video about sepsis. I hope you learned something new today. So if you like the content of this video, don't forget to like and then subscribe, and also don't forget to hit the bell button so you wouldn't miss our future videos. To my subscribers, thank you very much for subscribing. I hope you'd stay, and for now, I'll see you later. Bye!